approach.
Being welcomed by Neil for that talk and talking after Evan is for me too much. So no disclosures. So I'm presenting with Evan Zahn, and honestly, it's much easier and it's much better for me than presenting against him. Evan, maybe you don't remember the first time we discussed together was actually a dogfight at PIX where you commented that, closing a perimembranous VSD was a crime. Do you remember that? Yes, sounds criminal. But this was the nadir of our relationship the first time, and I must say that since then, it's just been improving. And some months ago, actually, Evan wrote to me to ask me advice about a case he had done of perimembranous VSD closure. So now Evan and I are brothers in crime, which is probably the highest level of relationship between two guys. Actually, there's a last level that we won't achieve. Our wives can sleep quietly, okay? But it's presenting after you, Evan, is an honor and a very humbling experience because I know your work and your work is very excellent. I will concentrate on differences, subtle differences about our approach, knowing that catheterization is like cooking. We have different recipes, and at the end, the taste is the same. And this is about PIX. This is what we are doing at PIX, is comparing and having nice discussions. So the title, A New Method, is that a new method? Neil started almost 10 years ago, and the ADO2AS is available, at least outside US, since about 4 years. So it's not new. It's still an emerging method, as you said, which is surprising considering what the alternative is. And you did it, so I'm not going to go through, but surgery, which is as good as it gets, still has a lot of morbidity. And one thing astonishing is 40% in some studies of vocal cord palsy when you look for it. It's almost routine that they will get away with the left laryngeal nerve. And as Neil pointed many years ago, it would be a logical target to close it percutaneously and avoid a thoracotomy in those very, very sick patients. And here we are with the wheel and trying to sell it to other peoples. And the reason actually why it's not still a routine intervention, it's because the guys we are trying to sell it through are not pediatric cardiologists. They are neonatologists, which are very, very conservative people. And in the back, you can see here, this might be a surgeon who is hostile sometimes. Your surgeon seems to be very supportive, but sometimes the surgeons don't want to get another intervention out of their hands. And in the back here, probably the wise guy here is probably from a regulatory agency who's looking at those devices and saying, it's not written for premature, so you shouldn't be using it for prematures. So this environment is difficult to overcome, and this is why 10 years after, there's actually very few people doing that, and it's a wonderful procedure. So what are the differences? I acknowledge everything you said, and your presentation was excellent. I'm going to concentrate maybe on the differences. I personally consider the PDA of a premature as a PDA of a fetus. I will explain to you later. Of course, the ADO2S, I'm sorry, it's there. The ADO2S is the best device, and I think we agree. I do strictly transvenous approach. We will argue with Neil. And I put the device completely inside the tube, nothing sticking out or compressing the LPA. Because I feel that when there is a pulmonary end narrowing, this might be reactive. And it might come away 10 minutes after you put your device, and then your device will embolize into the pulmonary arteries. And of course, like you and like everybody, we need to minimize morbidity in every step. So of course, most of those ductuses, as you know, are type Cs, perfectly tubular. Sometimes you will have a type E with a pulmonary narrowing, but in my head, this pulmonary narrowing is not part of my evaluation because I'm not sure it will be there in 5 minutes. Okay, this is what looks like a real tubular PDA. And then, of course, if it's tubular, it's not the pulmonary end that I'm going to look. It's the average tubular diameter that I'm going to choose for my device. And again, usually, as you said, these ductus tends to be rather long, and the diameter, when fully not expanded, but fully dilated, sometimes, like in a fetus, will be pretty much the same as the descending aorta. So, knowing that, when you have the device with a retention disc, I will choose a device which discs are 150% of the tubular diameter, not take into account the narrowing. If I take it with the lobe, the size of the device itself, it's going to be slightly larger than this, so the disc will definitely, of course, oversize. And frankly, at the end, what I'm doing now is just measuring the descending aorta by echo, which is very easy, and this to me is the maximal diameter of my tubular duct, and this is what I take now as my diameter for plug selection. So these are the devices I've been using, 1ADO2, very bad idea. When the other ones were not available, I did some patients with the plug 2. In between, I had some cases with the plug 4, but when the ADO2AS came into market, I really came, very attached to that, and all my cases now are done with the ADO2AS. It's an hybrid device between an ADO2 and a plug 2. It means it has two retention discs, but only slightly larger than the central occlusive lobe. So the compressive forces will almost not elongate this device, contrary to the plug 2, where all the devices is elongated when it's compressed by the PDA, which means that you can put devices in much shorter PDAs, and you will not need to have them go on the LPA side, because you can put everything into the ductus. Most importantly, it goes into a delivery catheter, not a sheet, a catheter for French, which is even better than a sheet. And the current sizes apply to the smallest prematures. Maybe the problem is when you have a baby 3.5, 4 kilos, where the 5 sometimes can be too small. Very importantly, like you pointed out, even if you embolize one device, like Jose Luis did, you can retrieve it and put another one. So to me, it's definitely the best device for prematures when you have it, of course. And I would accept a debate. It's the only debate I would do with you, because you would kill me in the other ones, but I would debate with you, but I think we agree already. Now, I would accept a debate with Neil on the fact that it should be put transvenous and not transarterial, although this time I would want it in French, because Neil is a shrewd debater, and I would need some advantage. He has some points in favor of the arterial approach. It's faster, it's easy to guide by TTE, much easier, and it's extracardiac. However, the limit of that, as you know, is what you do to the femoral artery, and this is a case that I presented at PIC some times ago, and this case, of course, he had a lot of compromise of his leg. And if we want to go under 1 kilo, I think it's just not possible to continue doing it in arterial. So I completely switched to, no arterial puncture at all and transvenous completely. I put my devices inside completely the ductus, because I have very short devices. I don't think we can do it necessarily with the plug 2. But Neil, who has the ADO2AS, still has the device. I don't know if you still do it like this, sticking in, one disc in the LPA like a regular ductus. I think to me, this is just more risky for embolization. And in fact, I'm not going to show it, but this device embolized eventually because the PDA just dilated a little bit and the device can embolize. So I really, again, would advocate for putting the device as close as possible to the aorta and completely inside of the PDA. We have to say that all the sizes of the ADO2AS go into the same 4 French, so we don't need to put bigger catheters. And it's very soft. So although we are stretching the ductus, I don't think we can injure a ductus with such soft a device. And I would debate with you on that, with you both, and maybe with Jose Luis, who also does the same. Very quickly, yeah, 1 minute. So this is how we do it. We put like the catheter, we do an angio, we follow a lot by echo. We measure length, diameter, both echo and angio, and usually the correlation is very good. We choose a device. In this case, ductus was 4.7, aorta 4, so we took a device 5, and since the ductus was very long, we put a 4 millimeter length. We could have put a 6 or even a 2, doesn't matter. So this is first deployment. You can see immediately that the device is too much into the aorta with some turbulence into the aorta, so the device is very easy to reposition. I'm done in 1 minute. And you can see immediately that the device is perfectly aligned with the aorta. It's here and no turbulence, so it's exactly what we want. We want it flush with the aorta. Okay, then as you do, we measure the disc to be sure that they are compressed, means that is not going to move. Look at all the space we have until the pulmonary artery, and this device cannot go anywhere. Actually, you see that the ductus now is smaller at the beginning because it spasms, okay? And by echo, you can see the same. The device is completely inside the ductus. You can see it here, a little bit of thrombus to the wire. And then we detach the device, and of course we do the echo. I'm not going to show you that. The echo is like before, everything is fine. Just for a detail, look now at the pulmonary end, how bigger it is. So I don't rely on any pulmonary end narrowing because I know it might be there and not there, so I don't rely on that. Okay, of course, we're very careful. I'm not going to go into that. Just to tell you that we cannot do it in my hospital bedside with fluoroscopy, and it's I'm very sorry for that because I know you're doing the good thing, but we rely more and more in the cath lab on echo, and for the few minutes we will use the fluoroscopy, including during deployment. It's going to be, well, this doesn't play that well, but it's going to play at 3 frames per second. So that's it. We need technical advances, and I think and the company should probably assist us better. Bigger devices, special catheters for echo guidance. We should randomize now against surgery, and then hopefully we will prove the septics wrong. Sorry for the delay.